This is a recording of a patient journey through the theatre department to address DS07. We will be taking a patient through the journey that's depicted here, starting with the theatre schedule, pulling that patient from a prioritised waiting list queue to get the patient scheduled into a specific theatre with the appropriate conflict checking. We will then move on to a pre-assessment activity where we're seeing the patient in a pre-assessment clinic being reviewed by the anaesthetist to ensure that he is fit for surgery. Then take a look at the theatre management dashboard so that the administrative staff can look at throughput through the theatre department. We'll then take a quick look at the perioperative tracking, how we can track those patients through the theatre department, moving on to clinical documentation as a preoperative nurse, intraoperative nurse, anaesthetist and the PACU nurse, then finish with a brief overview of some of the reporting and analytics tools that you'll have available. We will begin the journey by looking at the waitlist queue. This is a prioritised list of those patients that need to be scheduled into particular theatres based upon those waitlisting priorities. At this point, we'll be looking at our patient, Mr. Blake Boylston. We can see him listed on a list of patients that need to be scheduled through the waitlisting process. At that point, we can go ahead and schedule Mr. Boylston. At this point, we can review the particular procedure that has been requested, which is a total knee replacement of his left knee. We can also evaluate any key duration information. How long does it typically take that particular surgeon, in this case Mr. Peaks, to do that knee replacement surgery? The system is auto-calculating those for you so that you can get a better idea of how long it typically takes to do that procedure. Any of those could be overwritten if appropriate. We are also capturing the setup and cleanup duration for that particular procedure so that we can ensure that we have appropriate turnover time between those cases. We can also review any special equipment requirements to ensure that we're conflict checking, to make sure that we have everything that we need to perform Mr. Boylston's surgery. At that point, we can see that listed in the work in progress. And we can begin the scheduling process. We'll be scheduling Mr. Boylston to come in on the 28th of December. You'll notice that we do have block scheduling or slots of time that are dedicated to particular surgeons or particular services. In this example, we'll go ahead and put him into the orthopedic block at 8 o'clock. Once surgery is scheduled, the closed red books that you'll notice in the upper right-hand corner are an indication that there are no conflicts. Everything is clear and we can commence with go ahead and confirming him for his procedure. At that point, the procedure is being confirmed. A case number is being assigned to that particular procedure and any relative instructions or preparations are beginning to generate. This can be information that can be provided to the patient or perhaps even sent to the electronic patient portal. So when Mr. Boylston is at home, he could review any of these preoperative instructions. At that point, he has been confirmed into that orthopedic block for a period of time with Dr. Peets for his particular surgery. During that scheduling process, Mr. Boylston was also scheduled to be seen in a pre-assessment clinic, and that's where we're going to pick up with the journey of Mr. Boylston. Here we're seeing an electronic schedule of all the patients that we will be seeing in that pre-assessment clinic. So as the anaesthetist or other healthcare professional who's going to begin to evaluate Mr. Boylston prior to surgery, they can see the patients that are actually scheduled to come into the clinic. We can see that Mr. Boylston has been checked in and he's ready to be seen. At that point, we can go ahead and select the patient to go into the chart to begin that clinical review and begin to generate that electronic assessment. Demographic information is displayed clearly at the top. We can see key information about his allergy history, heights and weights that may have been documented by those pre-assessment nurses as Mr. Boylston is coming into the clinic, as well as the picture of the patient in the top left-hand corner. As we begin to review, we can see that the system is smart enough to know that we're in a pre-anesthesia assessment process, that we're ready to evaluate his information, and we can say that he's coming in for the osteoarthritis of the left knee, and ultimately he's going to be going through a total knee replacement of that left knee. Any of that historical information can be reviewed. This allows us to review any past procedure history, for example, to see what other procedures have been completed. We can also see any particular family history that might be relevant for us to review. Any vital signs that have been captured by those preoperative nurses or by those assessment nurses, we can see that clearly here, as well as any laboratory results and any studies and examinations that perhaps we want to trend over time. We can see that information very clearly, begin to understand Mr. Boylston's health history, and begin to look at those laboratory results. In addition, any of those key diagnostic studies that may have been ordered and may be taking place during the assessment process, we can begin to review as well. For example, we can see that the chest x-ray that has been completed, so we can review to make sure that Mr. Boylston's lungs are clear and that we're not going to have any issues from a respiratory perspective. In addition to reviewing the report, you also have the ability to review the image without the need to launch out to any other viewer. We can do that directly from within the patient's EPR and review those chest x-rays. The same is true for any of those ECGs that may have been documented or reviewed, so we can review those directly within the chart as well. Again, we do this to make sure that we have everything that we need, that he looks healthy, that we don't anticipate any issues with his surgery. At that point, we've done a quick review of his health history, and we're ready to begin to pull together an assessment document as the anaesthetist. So as we move to the document section, we can also see that any of those consent forms have been signed by Mr. Boylston. This can be an electronic consent, or it could simply be a consent form that is perhaps signed on paper and scanned directly into the patient's chart, so we'll support either of those functions. Of course, the most efficient way would be to capture that electronically, allowing Mr. Boylston to sign an electronic consent so that's published into the EPR so everybody has access to it. To begin Mr. Boylston's assessment, we're going to do this through a standard template that allows you to capture that information very quickly. And from a drop-down menu, I have access to a list of assessments, including one which is a template for the knees that I would typically see. This is a structured document that's pulling information together that's already documented in the EPR and is beginning to generate the assessment document that you're seeing here. We're going to focus a lot of our time on the physical exam, where we can start reviewing his general health history, do the physical exam, and really focusing in on the airway assessment. Here, all things being equal, everything is relatively normal. However, if we do find an anomaly during the airway assessment, that can easily be documented. So, for example, we may see that perhaps there's a tooth that might be chipped, and we want to make sure we document that. We can expand the section and go ahead and say that patient does have a chipped tooth. And if we want to take it a little step further and we want to go ahead and insert an anatomical drawing, we can do that here as well. We can document very easily where the tooth is chipped. Again, that becomes a relevant part of that patient's history, especially where there might be intubations involved. Our final step is really to pull together the assessment and plan. For the knees that are typically done, we have a default assessment with classifications. In this particular example, we're going to do a spinal on the patient, and we're capturing that information here so that we have clear understanding of the type of anaesthetics that are going to be used, the plan for Mr. Boylston. At that point, we'll go ahead and sign that assessment and get that into the patient's chart. Any titles can be changed, so if you have a particular type of title that you want to use, that can be put in here as well, and that assessment can then be signed and completed. That becomes a document in the patient's EPR, so that healthcare professionals can review that information very clearly. We can see that's there now, and when Mr. Boylston comes in for his surgical procedure, we'll have access to that document. We'll have a clear understanding of the type of procedure, the type of anaesthetics that are going to be used. Let's fast forward in time, approaching that day of surgery. Before we pick up back with our patient, let's take a look at those electronic management dashboards that you might have available to really begin to understand the throughput through your theatre department. This example shows case progression. So the cases that have been scheduled for particular procedures, cases that have been added on or cancelled. There are also views that show you patients that are in recovery at that point in time. So really a real-time view of some of those key performance statistics that you might be interested in for your theatre department. We can also see cases that have been cancelled on the day of surgery, an important statistic to really understand those types and the volume of the cases that might be cancelling on the day of the procedure, as well as those first case on-time starts, subsequent on-time starts, and any of those cases that may have been added on. We also have the ability to review PACU volume, the ebbs and flows, the patients entering those recovery areas, so you can begin to understand trends with those patients that are entering recovery and hopefully avoiding any bottlenecks or any issues with patients moving from theatre into the recovery area. We also have the ability to review any of those cases that have had late starts. So again, you can begin to understand the throughput issues, any issues around those cases that are having late starts, and ultimately begin to drill down into those and begin to understand if there are any particular surgeons, patients, groups, or procedures of any kind that might be affected. At this point, we're going to start that process of some of that clinical documentation. We're going to play a couple of different roles. We're going to begin first as the preoperative nurse that's going to be seeing Blake in the preoperative area on that preoperative ward, beginning to review his health history, beginning to understand the procedure that we're doing. We're going to complete some of the checklists, but we may want to review that information in the context of really a tracking view. That real-time view of the patients that are actually moving through your theatre department. This is an example of one of those tracking boards. Again, these are configurable, so you ultimately have a design control over the columns that you might be displaying here. This particular view shows information about when cases are starting, who those patients are, cases that may have been added on the same day, for example, allergy information, as well as actual real-time statuses of where the patient is in their surgical journey. This is based upon documentation by your healthcare professionals. So as they're doing their documentation, this column, whether it be with icons, with colours, with text, will electronically update, letting the theatre staff know exactly where you are in this process. We can see procedural information, what procedures were scheduled, as well as any staff members that are beginning to be assigned to those particular cases. This allows us to make an assignment to ensure that we have appropriate staff members in the particular theatre or assigned to a particular surgical case. They'll display here, but will also display in our case attendance when we're ready to do that clinical documentation. Now, it's common for family members to be in that waiting area, so if Mr. Boyson's spouse is in that waiting area, this is an example of a view that could be displayed in that area in a public space. You'll notice the patient's name is not listed here, but in its place is a case number, so that the case number could be provided to his family member. They could see that information very clearly and be able to track that information as Mr. Boyson moves through his surgical journey. Your secondary view of tracking is the dynamic view, and that's what we're seeing on the screen currently. Commonly called a swim lane view, we can see that we have our theatres listed on the left. We have timescales listed at the top, so we know exactly what time it is. So essentially, it centers itself around real time, and then we have the ability to watch those cases as they're moving across the real time marker, based upon milestones that the trust actually defines. We can see here at the bottom that we're tracking essentially 5 milestones from the point that room is being set up until the patient is actually leaving that room or out of theatre. So for example, we can see cases that are progressing and moving forward. So we can see, for example, that this case is ongoing. We can also see this case for a 13-year-old for tonsillectomy, which is also ongoing. It provides a real-time view, a very longitudinal view of how cases are moving through your theatre. This is a drag and drop, so it does allow you to shift cases very easily from one theatre to another, or from earlier in the day to later in the day, so it becomes a good control mechanism to ensure that if cases do get to move, you can move them as efficiently as you need to from here. At this point, we can see that Blake is there in Theatre 1. We're ready to begin his assessment for a pre-operative perspective, so we're going to go directly into the patient's chart. We can do it directly from those tracking views, so that access into the patient's EPR is done quite easily. You'll notice that we have the same demographic information there at the top. Again, that consistency across the EPR. I can see, for example, that he does weigh 80 kilos. So that might have been captured even during the assessment process when he was in the pre-assessment clinic. So again, that longitudinal record, that single source of truth, so that we know that we have had a clear picture of Blake's health history. As the preoperative nurse, there are key things that I want to focus in on, and I can see this very quickly through this preoperative summary view. It gives me a concise summary of information about Blake. First and foremost, I can see that he's scheduled for a left knee replacement. To the right of that, I can also see that we have our preoperative checklist completed. We have the ability to evaluate his nil by mouth or NPO status. And I can also validate that we do have those consent forms signed. We also have, for example, those ECGs. If you remember, we looked at the ECG in the assessment clinic. So we have the ability here to review that information. We also have a complete view of those documents. So I can review that the anaesthetist consultation that was done during the pre-assessment process that we just finished. We have the ability to review that information, review again any of those consent forms that may be electronically signed by Mr. Boylston during this process, and any of those surgical consents or anaesthetist consents that maybe need to be signed electronically and placed in the patient's EPR. I see the most recent vital signs as well, and you'll notice I do have access to this history. If I did need to dig a little bit deeper and see more of that information, then I certainly have that capability. For example, if I want to review his family history, I could expand that component or panel and review that information. Keep in mind that the view that you're seeing is configurable. You have the option to design this in a way that the trust feels appropriate. So if there's key information that you want to see, a certain panel, certain information that you want to ensure that it's expanded and brought to the attention of your healthcare professionals, then you would certainly have the capability to do that. Any of those lab results are accessible as well. We looked at those lab results in the pre-assessment clinic, but if there's anything that we want to review, for example, if we wanted to look at that white cell count, again, we have the opportunity as well to review that information in textual form or in tabular form, as well as seeing a graphical trend as you're seeing now. We can also see that Mr. Boylston has been started on a care pathway or plan of care for his knee replacement surgery. A care pathway or plan of care is simply a set of orders, typically separated out into phases, so we could have a pre-assessment phase, a pre-operative phase and a post-operative phase, and these will follow the patients on their surgical journey, reducing variation in patient care. As the patient moves through these various stages of their surgical journey, the healthcare professional can essentially initiate that phase of the plan that is appropriate. So if we take a look at what the care plan looks like, to the left-hand side we have the total knee replacement care plan with the pre-operative and post-operative phases. The pre-operative phase is initiated, and as the pre-operative nurse on the ward, I can see if there are any pre-operative medications that might be appropriate for Mr. Boylston, any fluid that might need to be started for him, and this allows us to review that information very quickly. We can see that the peripheral IV has been placed. We've documented that here so we know exactly the site of the peripheral IV or multiple IVs. We know that it went into the antecubital. We know the size of those IVs, the type of those IVs that have gone into Mr. Boylston, so we can begin to administer any of those preoperative medications, those fluids that need to go into Mr. Boylston as he approaches his surgical procedure. At that point, we're going to go ahead and begin that preoperative assessment. So, this allows us to capture that information, Keep in mind that we have a complete view of the history, so any of the information that was captured during that pre-assessment process we can see very clearly. It gives us that starting point. We can review that information and start to begin to review those trends in this flowsheet view over time. At this point, that assessment can begin. We can begin to capture information. This can be captured again if this needs to be. You can see that I'm entering the information here, but if I were going to put that patient onto a monitor, for example, then we can capture that information very clearly directly from the monitor electronically, reducing the time taken to document those vital signs, but also reducing the possibility of transcription error. That device integration strategy, where via Cerner you're going to pull that information directly from monitors, we'll see that very clearly as we begin to move Mr. Boylston into theatre. When we start looking, for example, at the anaesthetic record, we'll see a clear picture of how those vitals will be coming in. During the assessment, measurements will also be captured. While I'm capturing that information to ensure that we have the appropriate height and weight documented, you'll also note that the BMI calculates automatically. I won't do the entire assessment, but all of that preoperative work can be completed by simply selecting the appropriate section on the left-hand side and completing the information within the flowsheet on the right. If there are no neurological symptoms, I can simply select no neurological symptoms, but if there were, then I would be able to begin to document further. In the example of pupils assessments, I can select that section and then begin to capture that information clearly during the assessment process. Any pain that the patient may be in, we can capture that. He's still in a little bit of pain, we can capture that information. He is able to self-report that pain, and we will use a numeric scale. The pain currently is about a 6. His knee is painful. There's a little bit of swelling, some radiating pain with that left knee, and we can capture that here. Certainly we would like him to have a pain score of 0 by the end of this process, but then we could begin to capture that information that it's his left knee, it's radiating, it's a little tender, a little bit of throbbing that is occurring, and then I can capture it's pretty much a constant pain, but it's been a gradual onset, as you would expect with osteoarthritis. Once that full assessment has been completed, that information can be signed and pushed into the patient's EPR. So essentially, again, I've captured some of that key information preoperatively, didn't do the full assessment, that hopefully giving you the idea of how you could capture that full preoperative assessment. If this were a day surgery patient, if we anticipated that Blake was going to be going home the same day, you have some condensed views that allow you to capture just simply the information. For example, if he were coming in for an arthroscopy as opposed to having his knee replaced, he's going to come in that morning, have his procedure, then go home relatively healthy. The system would recognize that, and we can capture a less involved assessment. We know that he's not going to essentially be transferred to a ward, so being able to capture that information very clearly, it gives you an example of how you might address patients that might be coming in just for that day surgery at that point. At that point, the peripheral IV is in Mr. Boylston, and we can begin to administer medications or perhaps start some fluid on the patient. That can be done from the medication administration record, the MAR, the drug chart. We can capture the information there. We can also do that via barcode scanning using the medication administration wizard to ensure that we are capturing the 7 rights of barcode administration. The patient's armband would be scanned to ensure that we have the right patient. At that point, we'd see the medication that are available to be administered at that point in time, the right time. We would scan the medication barcode to ensure that we've got the right medication, the right dose, the right route. Of course, we'll be assessing that we're giving the medication for the right reason, and the mandatory fields will ensure that we're completing the appropriate documentation, so ensuring that we're documenting the site of administration of the medication. We can then sign completing the documentation process. So we've initiated some fluids preoperatively for Mr. Boylston. We've done a brief overview of some of the preoperative work. And he's ready to go into the actual theatre, and we can do that documentation directly from here. Again, we can access, as the theatre nurse, the documentation that is appropriate for the knee replacement for Mr. Peaks. We can see my documentation panel on the left-hand side, and that's going to be my navigation panel that allows me to review key documentation that's appropriate for this particular procedure for this particular surgeon. At this point, we're going to go ahead and say the patient was in the room, and we can do that quickly and easily by just pressing one button, and that puts in the current date and time so we can begin to capture the information. That information is going to flow back into the tracking boards that we looked at the very beginning of this process. It's also going to flow into the anaesthetic record. Again, because it's one system, we don't want to necessarily have the anaesthetist document again that the patient came into the room if the nurse has already documented that information. Any of those case attendees are clearly defined here as well. So being able to understand who the attendees are, what role that they're playing, so we can see that we have anaesthetists, we have surgeons, we have scrub technicians, we have circulating nurses and theatre nurses. You may have a perfusionist in the room, again providing a clear picture of who's in the room, the times they were actually in theatre with the patient, being able to capture that information very clearly. We also can capture those safety checklists. This is the World Health Organization. The WHO checklist is in the 3-part format. We can capture that sign-in process, as well as any of the timeout. When that timeout was taken, when the pause was actually taken, and then ultimately when he is actually ready to leave the theatre, being able to capture that timeout process. The green check marks or indications that the documentation has been completed or that section of your theatre record is completed, so it provides a nice summary and nice audit of the information that you're actually collecting. You have your electronic pick list. This is where you can document what items have been consumed or supplies, disposable supplies, perhaps implants that are being documented. It gives that theatre and us access to what was brought into the room, and then provides them with the mechanism to document what was actually used during that procedure. So this could affect inventory control. We can feed this through Cerner's clinical supply chain solutions, or perhaps this get transmitted to a materials management system that might be in place at the trust so that they have a better understanding of what's being consumed within the theatre. So if they're going to do any type of reductions of their quantities on hand, or if you want it to kick off any procurement activity, then we can do that directly from here. Now, of course, with Mr. Blake's knee surgery, he's going to have an implant or implants. We can capture those directly within the implant log. We can also capture that, just like you saw with the medications, with that barcode scanner. So in this case, the theatre nurse could simply pick up the barcode scanner, scan the information, capture relative information about that particular implant, such as a lot number, for example, expiration dates, key information that might be housed within that barcode scan. That information is going to update the electronic pick list. So we look at that implant, we can see that the Vanguard implant that has been scanned, but more importantly, that is captured back in our electronic documentation as well. So we can capture, we can see it's already there. I can simply augment information, all of that manufacturer, the lot number is now completed. I can see that we have the expiration date. And perhaps I just want to be a little bit more specific that, of course, this went into his left knee. And if there were any particular outcomes that you met or nursing assessments that were completed or outcomes, being able to capture that information here as well. Any fire risk assessments or counts verification, all the things that you typically think of when you're actually doing a theatre record, we're capturing here. Being able to deficit check those, make sure that they're being completed appropriately. Again, those green check marks are a clear indicator that the documentation is actually being completed. At the same time, there's an anaesthetist involved with this particular procedure. This is an example of that anaesthetic record for Mr. Boylston. It may have been started in the preoperative area. At that point, they could have opened the anaesthetic record, launched what we call a macro. Their macros listed here. This allows us to pull relative information about that procedure and make sure that we're administering the correct medications and then being able to capture that information clearly. For example, here we did do a spinal, so we can see that information that might have been captured preoperatively before the patient perhaps even came to the theatre. So we can see some examples of information that's been charted, key information like levels inserted or attempted, so being able to pull that information very clearly into the system. Any medications that have been delivered, we can see a listing of those here, including their cumulative volumes, as well as any data that's being pulled directly from the monitors in the theatre or the anaesthetic machine, being able to pull that information and see that very clearly. Any additional documentation can be pulled from the to-do list that's been populated from the macro, so again provides me a very efficient way to do some additional documentation. So for example, if I wanted to start a propofol infusion, I can do that directly from here. It's important to note that that information will flow directly back into the patient's EPR so that the drug chart is updated. Intakes and outputs are actually updated as well, so as the anaesthetist or healthcare professional documenting that estimated blood loss, for example, or urine catheter output, we're going to have that information flow back into the chart. So when the patient ultimately moves into recovery, we can see that information. At this point, we've talked a little bit about what the theatre nurse does, a little bit just a kind of high-level view of the anaesthetic record. He comes through his procedure relatively well and will ultimately be moved into the recovery room. Changing hats, I'm now back to being the PACU nurse, and I begin to look at that summary view of information. So it allows me to look at the summary of the documentation that's been occurring throughout the procedure. So I can see, for example, the information related to the implant. I can also begin to evaluate some of those inputs and outputs, those fluid balance, and being able to see information that's coming in from the theatre that was documented on the anaesthetic record. For example, fluids, any medication. So, for example, we can see that there was some fentanyl administered, and we can review that information directly. Once the PACU nurse is ready to do documentation, they can complete it in a very similar way to the flow sheet view that we saw preoperatively. I can document how the patient arrived in PACU, as well as being able to document how they were identified when they came in. He's in a supine position, and then we can capture any of those relative vital signs. Again, being able to capture those either manually in the patient's chart or perhaps capturing that information directly from the vital signs monitor themselves, so that information is brought in directly. Any relative assessments that you might be doing there at the trust, this happens to be an example of an Aldretti type of assessment, so we can begin to assess the patient and see if he can be moved out of the recovery area, perhaps onto the ward at that point. Once we feel that he can, I can then begin to do that handoff documentation. This allows us to capture key information around how we're going to report to those nurses on the ward, how we're capturing that information so that we can have a clear documentation as Mr. Boylston is moving from theatre into the ward. So any equipment, how the information is being identified when the patient is actually being transferred, for example, and then who's giving those particular handover reports and who we're giving those reports to, so being able to capture that information very quickly. Again, any additional assessments, any pain assessments we can do directly within these electronic flow sheets. We can administer medications through the barcode scanner, and that's just giving you a high-level summary of what those PACU nurses are actually doing. We're going to finish our presentation with a brief overview looking at some of the analytics tools. The ability to look at information about the theatre, some of those key performance statistics. This is an example of being able to review case volumes, for example. This is a very graphical view of information related to those volumes. Surgical specialties, for example, surgeons that are actually involved. We can look at any of that surgical utilization, for example. This allows us to overlay a topographical map over where those cases actually originated from. Again, some very advanced reporting tools for you. We're also able to look at those relative case times, just providing another example here, being able to look at specific times related to those theatres, operating theatre utilization, for example, utilization by operating theatre or surgeon, any actual or scheduled utilization. So being able to take that information that you've been collecting during your clinical documentation, culminating it into very usable and consumable reports. This concludes our overview of the theatres experience. I hope that's provided you with a high-level review of the theatres solution and the patient journey. Thank you for your time.